my name is Avrika Savitskaite. I'm a co-founder of HelmetBasedVentilation.com. Today I have a pleasure to talk with Professor of Medicine, John Kress from University of Chicago. He specializes in all areas of pulmonary and critical care medicine. He also serves as a director of the Pulmonary and Critical Care Procedure Service. His research has focused on sedation for patients with respiratory failure and early interventions to reduce functional decline after the ICU stay. Dr. Kress also is a corresponding author of the 2016 Helmet NIV study, which was led by Dr. Patel at University of Chicago Medicine. So I have a pleasure to talk with you today, and I wanted to ask, how did you learn about helmets? When was it? It's probably before 2016, obviously. So can you tell us a little bit about it?
Yeah, the helmet is a clever idea. I actually first heard about it at a presentation conference in Europe, because the helmet's been used in Europe for many years prior to ever coming to the United States. And because our area of interest is in avoiding complications related to respiratory failure with intubation, I remember seeing the presentation and thinking, couldn't the helmet substitute for an endotracheal tube? And since it's less unpleasant, it might allow patients to avoid sedation, avoid immobility, and therefore the complications associated with those sorts of things might be reduced. So when I got back to the United States, I started thinking about it, and there were some papers that were published that had shown benefit, but the problem at that time, and this is probably in the, I'm going to say 2012 to 2014, in that time range, that the helmets that were largely used in Europe were not available in the United States. But I did find one paper that had used a device that was available and FDA approved in the United States, only one helmet, and that's the one that we used in our study that Dr. Bhakti Patel spearheaded, and that was published in 2016. And then the second idea was to try to look at a target population that was different than people with ventilatory failure, that is, things like COPD exacerbations and problems of ventilation, and rather to look at hypoxemic respiratory failure. And the idea there was that with the helmet, you could generate a much higher level of PEEP than with a conventional non-invasive face mask. So we started thinking about the idea of a study looking at people with hypoxemic respiratory failure who might benefit from helmet non-invasive ventilation, and that was sort of the foundation of the study that we put together and published in 2016.
Yes, and the study got a lot of attention when it was published in JAMA. And can you tell me what happened after that? Did you hear any changes in practice in other facilities? Did they try to use helmets for, immunocompromised patients or patients who will not benefit from the invasive mechanical ventilation? Did you notice any changes in that time period, after 2016 until now?
A lot of interest, but because it was new in the United States, and the helmet that we used was not necessarily an easy device to become familiar with, the uptake was very slow. I think really until the most recent problem with COVID, when it got resurfaced for obvious reasons. But the problem back in 2016 was, while the idea was very compelling and beneficial, it was difficult. There's a very steep learning curve with the helmet that we used in 2016. And so its uptake just wasn't extremely high. There were individual centers that were interested and tried it, but widespread uptake didn't happen. In fact, the companies that make the helmets in Europe, because of that very issue, when we talked to them about trying to work to get approval in the United States, just didn't have any interest, and that was a business decision because of the market was just not there for it at the time.
Yeah. So we kind of have like a chicken and an egg situation here, where you wanted to use the device, but you cannot get the FDA approval because it's not used very often in practice.
Yeah.
And I totally understand the manufacturers from Europe that it is very time-consuming and expensive process to bring a device to the US. So you did mention, learning curve during the study in 2012. Now, what was the biggest obstacle?
I think the biggest obstacle with the previous helmet, there were two. The device was not easy to put on in a sick patient. You have to cut the neck ring to the right size. Patients are in distress. And it was not easy to put on. And that made people more accustomed to go to what they were familiar with, which was non-invasive BiPAP with a face mask or straight to intubation. Even though we did the study, changing behavior when you were using an instrument that you weren't familiar with was a very big obstacle.
Yeah, so you did mention a good point, changing the behavior. So not every, to implement any new device, you need the whole team behind it. A lot of, champions for the Helmet NIV. And I remember at that time I was still working at medical ICU as a patient care manager. So we did take time to learn and, started slow, but I feel like after a while when clinicians started to see the positive benefits of this interface, it became easier to apply it. And I think it's like with any other devices that we use in a daily practice. Everyone needs to get used to it. Everybody needs to learn, create the protocols and everything. So did you notice that now when you are using helmets more often because of the COVID, these obstacles are not an issue on a unit?
I think they're less of an issue. They still, we still don't use it as much as we do non-invasive. And then, of course, the other piece that has come into the equation that wasn't there when we published our paper or was just beginning to come into the mainstream is high-flow nasal cannula. And every one of these devices requires some mass group to buy into it and then to get familiar and comfortable with it. And I think if you go back to the 90s when BiPAP with a face mask was used, when it first started, I remember those days. I was, fairly young in my career, but the initial use of BiPAP was very similar to the helmet. It was clumsy. It was not well viewed as a beneficial intervention. People were skeptical to use it because it just wasn't something anyone was familiar with. And that is importantly, as the technology began to advance, so that the machines that were ventilating patients, the face masks themselves, the BiPAP face masks, we started to get better, more comfortable face masks, easier to put on, easier to take off. The ventilator was much easier, giving reliable pressures, reliable oxygen concentrations. All of these things made non-invasive ventilation, I think for most people in 2021 who view non-invasive ventilation as just standard, everybody gets or has the potential to get that. If you go back to the early 90s, no one got it. And when we first started, it was very clumsy. And I think the helmet is exactly the same. Even high flow nasal cannula was a bit clumsy when we first started using it, but it's an easier tool. And so people developed a comfort level with it sooner. I think the big thing with the new helmet in the setting of COVID is the fact that we have easier to place devices that you can put on and take off the patient's head without the difficulty of getting it to fit correctly. I think that's been a huge advance.
Yeah, and in the recent year, the data shows that approximately about from 15% to 30% increase happened in non-invasive ventilation usage, which is very positive, you think, for, change in practice. So what, now you did mention about the, about helmet taking on and off and comfort. Can you tell me about, devices that you are using now? Because we have now 2 helmets that are FDA approved for the NIV usage in the US. And did you notice that it's much easier based on helmet design and features that they use?
Yes, I think the key advances are a couple. The first is that there are now helmets that you can put on the patient's, around the patient's neck, that come in different sizes. So the ring that goes around the neck is pre-manufactured. You don't have to take scissors and cut it. That's a very important advance. They come in different sizes: small, medium, large, extra large. You can, there's a inflatable collar that goes around the neck that helps to improve the seal. The other thing is that the helmets that have a way of getting access to the patient's face. So there's a lid or a screw that comes off that you can actually put your hand in, give the patient something to suction their mouth with, give the patient something to wet their gums or their lips or whatever might be distressing to the patient. And then just quickly put the cap back on, and the helmet reinflates very quickly. That sort of thing has really improved uptake, not only by the care providers, but also by the patients. If you take the older helmets off and try to put them back on, it takes a bit of time, and it can be challenging. And patients sometimes, in the midst of being severely distressed and breathless, may become agitated and no longer willing to wear the helmet with the older ones. The newer ones, I find, are much less likely to have that problem.
Yeah, so you are right. The patient anxiety can be a big issue when you're applying Helmet NIV. Now, another great benefit of the patient access is also that you can deliver uninterrupted non-invasive ventilation for longer periods of time. So can you tell me what was the longest NIV, uninterrupted NIV, that you had a patient who received helmet-based ventilation?
Well, I mean, we've had some patients. Yeah, we've had some patients that have had it for a week or longer. There's a recent paper that was actually published in JAMA earlier this year from an Italian group, multi-center trial comparing helmet to high flow nasal cannula in COVID patients. And I don't remember exactly what the longest was, or even if that was recorded, but my discussions with colleagues, and particularly in Italy, where it's had much more uptake and for a longer period of time uptake compared to in the United States, these patients can be managed for a week or sometimes even longer.
Yes, and this is what I'm hearing from the manufacturers in Italy, that it depends on the center, on the unit, and the experts who are using helmets, because then if you are really good on it, you can keep patients on a helmet for weeks. And I even heard the one expert from New Zealand who used it. In the UK, he had a patient who used helmet for a month. But now let's go back to, again, patient comfort. A lot of physicians ask question, how about the sedation? Are you giving a lot of sedation to the patients who are receiving an IV? Because we know it's very hard to find that, you know, best match dose and at the same time, you know, have a beneficial non-invasive ventilation.
So the answer to the question is we do use sedation from time to time. Unlike in intubated patients who traditionally were routinely sedated the moment you put the endotracheal tube in, which, by the way, I don't think is necessary, but that's been the traditional practice for many, many years. With the helmet, we don't begin with an idea focused on sedation, but rather focused on alleviating the patient's breathlessness. And the reason for that is that if the reason that sedation is needed is because you're feeling distressed and very short of breath, feeling like you're suffocating, feeling like you can't get enough air, if I improve that with the helmet, you may not need any sedation at all.
Yeah.
Having said that, there are some patients who, regardless, are going to need to be sedated. I think the drug dexmedetomidine has been a very helpful adjunct, and because dexmedetomidine provides some degree of sedation without suppressing respiratory drive. So typically we start with a no sedation approach, and those patients for whom sedation may be deemed beneficial, we'll use dexmedetomidine to see if we can alleviate the distress. If dexmedetomidine is not effective, those patients usually aren't going to tolerate the helmet, in my experience. Have I ever used additional drugs besides dexmedetomidine? Very rarely. It's risky. Certainly you can give a little bit of opiate, I suppose, and once in a while I'll do that, but I wouldn't advocate that as a standard practice, because I think you're getting into a risky area. It's really important to remember that not everybody is going to benefit from the helmet, and some patients will need to be intubated. Now, it is interesting to me that one of the things that we can't really tell in real time, but sometimes in hindsight we can, is that what I said is true. Some patients won't benefit from the helmet and need to be intubated. And indeed, some patients won't benefit from being intubated. Unfortunately, those people usually die. And so in hindsight, my anecdotal experience has been that for the majority of people who do not tolerate the helmet and require intubation, that population of helmet managed patients has a very high mortality rate. And so that doesn't mean you stop trying, of course, but I think if you are on the helmet and you fail, that demonstrates and strongly suggests that the individual in that category has a very poor prognosis, in my experience. Again, not to say don't try, but if you put a helmet on and the patient fails and you have to intubate, you need to say to yourself, this person is extremely ill and has a very high chance of not surviving.
Now, when you mentioned about the sedation, I just want to go back a little bit, because this is also used mostly when you are applying helmet pressure support ventilation or bio-level ventilation. Is that correct?
There are two ways to use the helmet, in my experience. You can either use the helmet, which is connected to a ventilator, in which case you have to use pressure support, or you can use the helmet with Cpap with the gas flow coming off the wall, not from the ventilator. Those are the only two ways you can use it.
Yes, and the issue with the helmet pressure support ventilation when you connect to the vent is that patient ventilator asynchrony. Did you have these issues with patients? How did you resolve them? Do you have any tips for the listeners, because that's what I'm hearing right now from other clinicians, that that's the hardest part, to get that better patient ventilator synchrony.
I do have some tips. There are a couple of problems with the helmet that's different than a tracheal tube with pressure support. Of course, the helmet has compliance, and so when the pressure from the ventilator is given during inhalation, what it initially does is inflates the helmet and moves the helmet up, with the neck ring being the most compliant part of the helmet. And it doesn't go into the patient's lungs because the patient's lungs typically are much less compliant than the helmet. And then, so what that often leads to in a pressure support mode is that the ventilator continues to give the pressure until it's programmed to stop, which is most ventilators, the offset time is 25% of the maximum flow. And that's a long time when the maximum flow is very high because the helmet is so compliant. So there are two things that have been shown in previous work by other individuals to improve the synchrony between the patient, the ventilator, and the helmet. The first is that the onset time of inhalation in the pressure support mode, which is as a default typically at 200 milliseconds, you can adjust that on the ventilator, and the lowest time onset in most ventilators is 50 milliseconds, 50, meaning the breath gets pushed in quicker, onset time. So if you change the ventilator from 200 milliseconds to 50 milliseconds, if you're not familiar with these are parts of the ventilator settings that are usually not modified, but your respiratory therapist will know how to do this. It's not hard. You just have to know which button to push on the ventilator. Go from 200 milliseconds, which is the default, to 50 milliseconds, which is the onset time of inhalation. And then the second is the offset time, which is typically a percentage of the maximum flow, which in most pressure support modes is standard at 25 to 35% of the maximum flow. Change it to 50%, 50. And what that does is it makes the breath end quicker. And so that more rapid delivery and more short time of inhalation before the breath ends has been shown in previous work, and we did it in our study to improve synchrony substantially. So just to review one more time, onset time 50 milliseconds rather than 200, and flow offset time 50% of maximum flow as opposed to the default setting, which is 25 to 35 depending on the ventilator. Those two things can help with synchrony substantially. The other thing that will help with synchrony a little bit is if you reduce the compliance of the helmet, and you can do that a couple of ways, but one of the ways to do it is to essentially reduce the amount of movement upward that the helmet has during inhalation. Sometimes you'll watch the patient and they almost look like one of those little bobbleheads going up and down.
Yeah.
If you put something on top of the helmet to hold it in place, it won't be as compliant, and the dyssynchrony that you see, in my experience, is less.
Also, the design of the helmet makes a big difference. So, for example, the StarMed helmet is designed more for the NIV or pressure support ventilation. It's smaller, it is less compliant, and also it has that inflatable cushion that you mentioned, which helps not just with keeping the seal, but also it reduces the dead space.
Yes. And then, of course, the straps that go under the armpits are the other thing. And some of the helmets don't come with those, but having something that's under the armpits that's relatively tight, as long as you're not putting pressure under the armpits, can also reduce the tendency of the helmet to bob up and down.
Yeah. So I think the advice would be to have a helmet as stable as possible on the patient's head, during the whole respiratory cycle and don't see those fluctuations. So the same thing applies to the helmet Cpap ventilation also, where you don't want to see the helmet internal pressures to vary too much during the breathing, exhalation, and inhalation. Now, you are using the helmet Cpap during the COVID pandemic, right? When you're not connecting the helmet to the ventilator, but you connect to the gas flow.
Yeah, exactly.
I noticed that a lot of doctors, we want to start with helmet pressure support ventilation. And sometimes I would give them advice like, try helmet Cpap first because it's much easier setup. Do you agree with that?
I do if you're treating hypoxemic respiratory failure.
Okay.
It is simpler. The key to the CPAP is that you need to have a fresh gas flow that's at least 50 liters per minute, 50. And the reason for that is that you want to make sure that you wash out exhaled CO2. And what we usually do is just hook the helmet directly up to a high flow nasal cannula apparatus, which can give whatever FiO2 you want at 60 liters a minute, 60, which will for certain effectively wash out carbon dioxide. And then of course you just put a PEEP valve on the expiratory limb.
Yes, and it's an easy setup because you can switch from a high flow nasal cannula to helmet in a very short period of time, and let the patient try Helmet NIV and see if we can benefit.
Yeah, the other nice thing about that is that you can unscrew the lid on the front of the helmet where the face is, and you can put high flow nasal cannula on the patient and then disconnect to the high flow nasal cannula from the helmet and hook it up to the high flow nasal cannula in the patient's nose and see if the patient is ready to come off the positive pressure. Some patients are, some patients aren't, but it certainly buys you a little bit of time when you're transitioning from one to the other. Much easier than actually taking the whole helmet off and removing the neck ring and all that. Yeah,
that's a good point. The weaning off is another topic that I want to talk about, because right now Dr. Bhakti Patel started a new study in August of last year, and it's about the early extubation for patients with acute hypoxemic respiratory failure. Can you share any thoughts, any lessons that you learned so far during the study?
Yeah, it's still very early. We were working in the middle of the pandemic. All of our research studies were sort of put on hold, so we're still in the very early stages of that. It has full plausibility, but it's too early to say anything at this point, I think.
Now, talking about studies, it was a recent study published in JAMA, and it's by Greco and colleagues about the effect of Helmet NIV versus high flow nasal cannula. Do you have any comments about the study?
Yeah, it's certainly very interesting. It's important to remember that this study was only in people that had COVID, but it reduced, did not change mortality, but it did improve the ability to stay off mechanical ventilation via an endotracheal tube, as I recall. And so I think it's a plausible alternative. I think the key question and the key thing that makes the helmet different than high flow nasal cannula is the need for PEEP.
Yes.
One of the things that was interesting to me in that study was there has been this description that's been written about, and since COVID became such a problem, about different phenotypes of COVID. The phenotype of COVID that is more typically seen with conventional, if you want to use that term, ARDS, which is airspace filling, very stiff lungs, and the lungs are amenable to PEEP with recruitment. But then there's this other curious group of COVID patients that don't seem to fall into that biological, physiological category. That is relatively high compliance or low elastance of the lungs. Compliance and elastance are just inverse of one another. And those patients don't seem to benefit much from PEEP. And so one of the things that was surprising to me in the paper was that they didn't make a distinction between those two phenotypes. I'd be curious to see that. But certainly for those patients overall, there was a benefit. Helmet with PEEP, airspace PEEP will improve lung recruitment. And not everybody with COVID has that. So I would hazard a guess that the patient's benefits were connected to a propensity to have lung recruitment in a good number of them. Although I don't know that to be true because it wasn't described in the paper, but that's based on what I know about.
Also, what I noticed in the paper that none of the helmet patients were prone. Can you tell me a little bit, based on your experience, how the proning during non-invasive ventilation improved or didn't make any difference for the patients?
Yeah, proning a patient on the helmet, figure out a way to have the patient able to rest their forehead and whatnot on the pillow without losing the neck seal. That certainly can be accomplished, but it's a little tricky. And so most of the proning that I'm familiar with in COVID self-proning is via high-flow nasal cannula. But I think that's just because you need to be sure you don't lose the neck seal when you're laying prone.
Yes, and this is why, again, some experts can make it happen during the Helmet NIV. Another study actually came out recently, was about the hypercapnic cardiopulmonary edema. And that was a very small group of patients, and it's done by Sforza and colleagues. And we did notice that even in hypercapnic cardiogenic pulmonary edema, helmet Cpap can be used and treat these patients. I know that we have a big population of COPD patients, and do you use helmet for the COPD patients?
We do sometimes. The problem with the COPD patients is that now my dogs are going to bark, sorry, is that they generally benefit so well from the BiPAP that there isn't as much of an incremental benefit from helmet compared to BiPAP. So do we use it? Yes, but the incremental benefit, in my opinion, is driven more by the benefits of PEEP and airspace recruitment, which is frankly why, way back a decade ago, when we first started thinking about the idea of the helmet for ARDS, we chose to target that population because it seemed like they'd be more amenable to benefiting.
And you would recommend helmet pressure support hypercapnic hypoxemic patients?
Oh yes, for sure. The hypercapnic hypoxemic patients if they have both problems, typically the hypercapnia is what I would call an epiphenomenon, meaning when your lungs are stiff from airspace flooding, you are going to be more inclined, all comers, to have trouble, because when your lungs are stiff and airspace filled, the energy expenditure with breathing is increased. It's harder to breathe. If your lungs are wet like a sponge, it's harder to breathe and eliminate carbon dioxide. And so the CO2 rise is usually a reflection not of bronchospasm or things of that sort, but rather just energy expenditure, because you're breathing with your lungs being so flooded. And so the ability to eliminate carbon dioxide is impaired. So it's not uncommon to see patients with pulmonary edema of any type to also have rising CO2, especially when you're looking at people that are debilitated, weak, or essentially just running out from an endurance standpoint. You know, a 21-year-old that gets ARDS may be able to sustain the elimination of carbon dioxide for a long time. But even that young, healthy person, eventually, if they're working so hard to breathe, will become fatigued and no longer able to eliminate CO2. So the hypoxemia is the major contributor, but the CO2 elimination certainly can follow.
Yeah. Do you have any patient story to share that like stuck in your head and you would, like to discuss with your colleagues?
You mean just in general?
About who used the helmet-based ventilation?
Yeah, I mean, I think the helmet is an important component of the management in some of these patients. I would say, as I mentioned earlier, that people that are more likely to benefit are people that have airspace filling, particularly if you're talking about COVID. And we noticed that in our experience during the pandemic when we had a closed COVID ICU. If you have a patient that's got COVID but doesn't have severe airspace filling and is extremely tachypnic, our experience was the helmet didn't help them very much. And, I think others have similarly reported that there's a significant fraction of people with COVID for whom the helmet will not be of great benefit. Those for whom it is of great benefit, in my experience, are those that have airspace flooding on their chest X-ray, as opposed to a relatively minimal amount of diffuse airspace flooding. And then, of course, in conjunction with other established therapies, most particularly dexamethasone. I mean, we've had a few patients in recent times who were, for all intents and purposes, going to be intubated, and we said, well, let's try the helmet, and had remarkable improvements, just like we did in our original study without COVID. You put the helmet on, and the patient's respiratory rate, goes from 40 to 16. Their saturation on 100% high flow nasal cannula goes from 88 to 97%, and their FiO2 goes from 100% to 60, and that happens in 30 minutes. Those are the patients for whom the helmet is most clearly beneficial. And I think it's important, just as you need to have this on your radar as something to focus on and an option for treatment, to be able to detect those people for whom it's going to be beneficial, but also those people for whom it isn't. And in my experience, if you put the helmet on the patient, and in the first 30 to 60 minutes there isn't a substantial improvement, you should think twice and identify this person as somebody who very likely isn't going to benefit. And I think the biggest error that people make, and they make the error with non-invasive mask ventilation too, BiPAP, is they put the BiPAP on. The patient is clearly not performing well, high energy expenditure with breathing. Saturation may be, in quotes, acceptable, but the patient is failing. And those patients, when kept on face mask non-invasive ventilation, will usually declare themselves in a pericardiopulmonary arrest type of situation. So when I put the helmet on somebody, I say to myself, the next 30 to 60 minutes is going to be extremely important for me to be able to say, this person is benefiting or this person isn't. And be very careful, because when you put the helmet on somebody, just like a face mask, suddenly their ability to communicate with the outside world is impaired, and they have a muffler on, if you will. You can't hear them as much. And the saturation may be okay because you're giving 100% oxygen. But if the patient is working extremely hard to breathe, the saturation is largely irrelevant, and that person needs an advance in the care to perhaps an endotracheal tube. And that gets back to what I said a few minutes ago, which is those patients, unfortunately, have a very poor prognosis, in my experience.
Yeah, and definitely you don't want it to delay intubation, where we know the outcomes are even worse.
Yeah, I mean, the nice thing about the helmet, if somebody's failing and they're going to need to be intubated, is that you can give them 100% oxygen reliably in preparation for the intubation. And that can perhaps buy you a little bit of time, but I do think, particularly for like at my place, of course, we have residents, the younger doctors, to be able to recognize that the pulse oximeter is not the most important piece of data. In fact, I see that error made relatively frequently, is the pulse ox looks good, but the patient looks terrible. And the ability to recognize that in a timely fashion is sometimes slow.
Yeah, and you said it right. So helmet can be like a bridge to the invasive mechanical ventilation, and that's what the hospitals who have a lot of COVID patients and have ventilator shortages, they do use helmets, to wait for that ventilator to be available for the patients.
Yeah.
Now, I thank you so much for the great conversation here. I will ask you just the last question. So what do you think is going to happen after pandemic with the helmet interface? Is it going to stay in the US? Are we going to use it more?
Well, I think now that there's more than one option, and that the options that are available have been developed for acute respiratory failure as opposed to hyperbaric oxygen, I think that this is going to become an option on the menu. I don't know that it will surpass high flow nasal cannula, simply because of the simplicity of the two devices. The high flow is just simpler, but especially with this recent paper that came out in JAMA, I think that the helmet is going to move from a very esoteric option to more of a mainstream option. And whether it'll be mainstream like BiPAP is in hospitals now, or whether it will be less than BiPAP but more than it is now, and how much more is to be determined, I think. But the newer interfaces are definitely simpler, and the simplicity will make people's comfort levels better. That's my prediction, at least. Thank you.
Well, you and Dr. Patel and the whole team behind this study that was done in 2012. You guys are the pioneers and the biggest champions of helmet interface here in US, and I hope to see this practice in every hospital and more people, saved and less intubations.
Okay. Thanks, Arka.